Now let's discuss about lower gastrointestinal hemorrhage. Lower GI bleed, it originates distal to ligament of teats, jejunum, ileum, colon, rectum and anus. Epidemiology, incidence 36 per 1 lakh population. Demography, more common in males, correlated with vascular disease and diverticulosis. Incidence increases with age. The hemorrhage severity, 1.2 ml per day loss of blood is normal physiological. More than 10 ml loss of blood is pathologically significant but not visibly apparent and is known as occult bleed and requires GUAC or FIT tests. The lower GI bleed etiologies are the Meckel's diverticulum, intussusception, mesenteric ischemia, angiodysplasias, classically in the cecum or the ascending colon, diverticular disease, which is common in the West, internal hemorrhoids, which is the commonest overall cause for the minor bleeds, fissure in ano. Etiologies can be further divided as vascular origin, angiodysplasia, mesenteric ischemia, ischemic colitis, inflammatory or the infection's origin, ulcerative colitis, infective or amoebic colitis, Crohn's disease. The neoplastic are the adenomas, carcinomas and the polyps. Congenital and anorectal are the Meckel's diverticulum, hemorrhoids, fissure in ano. Acute bleeding is most frequently triggered by mesenteric ischemia, angiodysplasias, Meckel's, intussusception or acute severe ulcerative colitis episodes. The clinical features: painless hematochezia with diverticular bleeding, change in the bowel habits with malignancy, abdominal pain with colitis. Acute bleeding presents with features of shock. Chronic blood loss occurs in piles, fissures, colitis. Presents with hypochromic microcytic anemia, tenesmus, subacute obstruction, loss of appetite, decreased weight, bloody diarrhea is seen in carcinoma distal to large bowel. Per rectal examination is must, which may reveal polyp growth and ulceration. Hematochezia is one of the features. Mass palpable in the upper abdomen, in right or left iliac fossa, or the mass of intussusception, which is sausage shaped. Presence of hematochezia does not guarantee lower GI bleed. 10 to 15% times it happens because of the upper GI causes. The right-sided colonic bleeding can occasionally present as melena rather than hematochezia due to long transit time. Acute bleed leads to tachycardia, hypotension and the orthostatic drop. 80% of acute episodes regress spontaneously. Chronic bleed presents with hypochromic microcytic anemia. The bright red color in stools suggests polyps. The fresh blood as splashes in the pan is suggestive of hemorrhoids. Blood mixed with mucus suggests colitis or the carcinoma. Red currant jelly stool is noted in intussusception. Maroon colored stool in Meckel's diverticulum. Most commonly, the left-sided pathology is the diverticular disease. It predominates in the sigmoid colon, the single most cause of most acute lower gastrointestinal bleeds in the Western population. It presents with painless hematochezia. The right-sided pathology is mainly because of the angiodysplasias, classically located in the cecum, ascending colon. A prominent vascular cause especially features in the elderly. If HB is less than 7, it is low risk. Transfuse 1 unit of RBC and then reassess. If HB is less than 8, then it is high risk patient, elderly or with coronary artery disease. Transfuse 1 unit RBC and then reassess. Transfuse RBC, plasma, platelets in 1:1:1 ratio and follow the Tromo protocol in hemodynamically unstable despite administration of crystalloids. The severe ongoing bleeding, transfuse 1 to 2 units of the RBCs. The initial management mimics similar to the upper gastrointestinal bleed. Large IV bore should be secured and oxygen should be supplemented and monitoring needs to be done. The diagnostic triage order set. We look for the blood, occult blood testing and endoscopic. In blood, we Look for the complete blood counts, LFTs, burn or the creat, coagulation profile, and occult blood is tested in stools by benzidine, guac method and FIT method. Endoscopic procedures done are the proctoscopy followed by sigmoidoscopy followed by colonoscopy. Proctoscopy helps us diagnose hemorrhoids. Sigmoidoscopy look for the rectosigmoid pathology. Colonoscopy helps to rule out polyps, carcinomas and colitis. The clinical timing for the colonoscopy. It should perform on a next available basis within 24 to 96 hours. A high quality visualization requires adequate bowel preparation. There is no difference in rebleeding or transfusion rates between emergent, that is the one done within 24 hours, and the early, done within 24 to 96 hours. The minor of the bleeding, around 0.1 to 0.3 ml per minute, are detected by the radionuclide scan, which is the most sensitive. The technician labeled RBC recirculates for 24 hours. The 0.3 to 0.5 ml per minute is tested by the CT angiography. When endoscopy doesn't yield a fruitful result, the test of choice for the ongoing significant bleeding with a high sensitivity of 85% and accuracy of 100%. If the bleed is more than 0.5 ml per minute, mesenteric angiography is opted for. It is both diagnostic and therapeutic. It requires minimal optimal conditions. The classical signs in angiodysplasia is early or prolonged filling of the draining veins on the vascular tufts. So just a revision, the tests done for the detection are the radionuclide imaging, CT angiography, mesenteric angiography and the colonoscopy. In all of this, the most sensitive is the radionuclide imaging, which detects minimum of 0.1 ml per minute bleed also. In the colonoscopy, preparation is must for better visualization. The 90-minute rule: in ongoing hemodynamically significant hematochezia, CT angiography is performed, which is the fastest and precise method for localization of the lesion. Then transcatheter arteriography must be performed ideally within 90 minutes, as delay may miss the opportunity for therapeutic embolization before spontaneous cessation of the bleed. Mesenteric angiography, the first target primary is the superior mesenteric artery, cannulated and imaged first. The vast majority of lower gastrointestinal bleed sources reside in the bowel segment supplied by this vessel. Cecum to proximal, 2/3 of the transverse colon. Secondary, the inferior mesenteric artery and the celiac axis, evaluates it sequentially only if SMA runs is completely negative. The modern management utilizes super selective embolization via distal coaxial microcatheters, minimizes post-procedural bowel ischemia risk compared to historic systemic vasopressin administration. Hematochezia, when observed, if the patient is unstable, resuscitation and ICU observation is done. Then colonoscopy when patient is stable, no source of bleed is identified, then the colonoscopy is repeated. Upper endoscopy, push enteroscopy, CTA and angiography are done. When no source is identified, laparotomy with intraoperative enteroscopy is done. When the source is identified, the specific treatment or the expected management is taken up. In stable patient, colonoscopy can be done within 24 to 96 hours after adequate bowel preparation, and the source is identified, the same flowchart is followed. The lower GI management, the unstable pathway and the surgery. The trigger for surgery: persistent hemodynamic instability, recurrent bleeding or requirement of more than 4 units of PRBC in 24 hours. The bleeding site is localized preoperatively. Segmental bowel resection is well accepted with lower morbidity. If bleeding site is not localized and active bleeding is present, subtotal colectomy, procedure of choice, but carries 37% morbidity and 11 to 33% mortality. If unstable and non-localized, the two-step method, temporary ileostomy plus delayed ileoproctostomy, is opted for. The targeted treatment, angiodysplasias, endoscopic fulguration therapeutic embolization or right hemicolectomy is performed. For polyps, endoscopic polypectomy is done. Colonic carcinoma, surgical resection is planned for. Ulcerative colitis, mesalazine, mesacol, enema or drugs or total proctocolectomy with ileoanal anastomosis. Mesenteric ischemia, massive small bowel resection needs to be done. In sigmoid diverticular disease, sigmoid colectomy needs to be done. As described earlier, 80 to 85% resolve spontaneously. The mortality rate 2 to 4% of the overall mortality. Death from the lower gastrointestinal bleed itself is rare. 3-year all-cause mortality is approximately 37% driven by patient comorbidities. The worst prognosis is noted in malignancy, variceal bleeding, secondary bleeding, onset during the unrelated hospitalization, coagulopathy, and the male sex. Best prognosis are the hemorrhoids, anal fissures, and the colon polyps. Thank you.